Hello, good morning, everyone. Welcome to the ASPA EEG Workshop presented by Patrick Pardon, Melody Long, and myself, Fong Chen Lui. First, I'd like to introduce ourselves. Patrick here really needs no further introduction. He gave us this fantastic lecture early on, which I hope you were able to benefit from and attend. As mentioned earlier, he's an associate professor of anesthesia at Harvard Medical School and the Nathaniel M. Sims Endowed Chair in Anesthesia Innovation and Bioengineering in MGH. He's an expert in clinical EEG monitoring in both children and adults. And he's got multiple publications on the topic. He's also actively involved in educating anesthetists in the importance of clinical EEG monitoring by way of lectures, workshops, as well as online courses and tutorials. So Patrick, would you like to say hi?
And, hi, everyone. Thanks so much for coming. This is a really fun workshop. It's the first workshop I've ever been a part of that is focused, entirely on clinical monitoring for children. So it's really a pleasure. And I have to say, I hope I can, give you guys a really good introduction along with Melody to kind of set up, in essence, really the star of the show, who is Chun, Dr. Bong, who's going to actually show you in practice how you actually use the EEG to manage cases in children. So I'm really looking forward to this.
Thank you, Patrick. And Melody here is she's our consultant anesthetist in KK Women's and Children's Hospital. She joined us from National University Health Service about 2 years ago, where she was an associate consultant, and she's also an patient experience officer there. So Melody is very invested in improving the perioperative experience in children and has extensive experience in managing quality improvement projects. Since she joined us in KK, she's become integral to our clinical and research efforts to really investigate EEG monitoring in children. I'm a senior consultant at KK Women's and Children's Hospital, and really seeking to improve the clinical anesthesia care of children through research, education, and of course, clinical care. My research interests include studying the effects of anesthesia in children, both in terms of infant brain development and also EEG monitoring during clinical anesthesia. We've been using EEG monitoring in KK really since it became available to us, maybe about 3 years ago. And I've been privileged enough to work with Patrick and his lab, and we regularly review and go over the EEGs from our clinical cases. So that's been extremely beneficial, and I'm really glad that we could really benefit from this. And we think it's really important for anesthetists to know the benefits of EEG monitoring and to know how to do this, right? And hence we decided to put together this workshop during the conference, and we really hope that you enjoy it and find it useful. So this is the first virtual workshop that we've done together, okay? And we're trying to reach a large audience. So as you saw from yesterday, we know we have to work with really a lot of technological constraints and challenges, okay? So please bear with us as we try to bring you this information the best way that we can, okay? So some disclosures first. Really, Patrick mentioned this. He's an inventor, pending patents on brain monitoring using the EEG, and he's also a co-founder of Pascal Systems Inc., startup company, which develops closed-loop physiological control of anesthesiology. Okay, Melody and I have no conflict of interest, but you'd be glad to know we did not receive any industry sponsorship for this workshop at all. So there's no industry influence for this workshop. So it's all clinical. Okay, great. So here's how we're going to do this. We will have a series of mini lectures, okay, interspersed with polls, because we really like to know your opinions about EEG monitoring. So we will also have a Q&A after Patrick's lectures. And then we can take some questions, because I know you're going to have questions. Okay, and then we also will have a Q&A at the end. We'll see how we're doing for time. Okay, I really hope that we have a lot of time to take questions. Okay, so basically, I will start off by getting us to think why we bother to monitor intraoperative EEG in children, right? Why don't we just do what we normally do, right? It seems easy enough. Okay, I think the fact that you're attending the workshop today, okay, or attending the conference shows that you want to improve the safety of pediatric anesthesia, like us, right? We all want to improve the safety of pediatric anesthesia. So between a child going off to sleep, undergoing anesthesia, and him waking up in the PACU, right? A lot of things can happen, right? A lot of things can happen to the brain, and we want to know about that, okay? We want to prevent bad things from happening. And to add to that, there are certain neurodevelopmental concerns in recent years, okay, about sedatives and anesthetic agents on the developing brain. So sedatives and anesthetic agents, they are powerful neuromodulators, we know that, okay, and they may have possible long-term impact on neurodevelopment. Well, certainly the studies in animals are very compelling. We know it happens. We see the basic signs of that evidence. But in humans, in clinical trials, the effects are kind of much less definitive, okay? But still, if we have any chance at all to minimize anesthesia exposure, we think that potentially may be beneficial, right? So, and if we think about it, when we monitor our patients when they're under anesthesia, we monitor the heart using ECG, okay, looking at the rate, the rhythm, and then we monitor the lungs. Okay, we have our SpO2. We looked at the respiratory rate, the tidal volumes. All these are pretty standard, right? We know how they work. Okay, but we don't monitor the brain. But that's actually the target organ of where our anesthetic drugs actually work. So it's a little bit ironic, right, that we're not monitoring the brain where we are actually trying to target. So, you know, I think part of that is that, I know I'll speak for myself, that we don't have a lot of knowledge about how it works in general, like how the EEG works. I certainly, you know, have to claim I'm not an expert in this at all, and we're all learning. But I think it's something that's really important for us to learn. So to me, doing what we're currently doing now is a little bit like driving in the dark, right? You have your headlights on, you have all these monitors and sensors, the speedometer, the sensors that tell you you're not going to bump into anything. So you're safe, right? You're pretty safe. So, but you're probably going to miss a lot of details along the way because you can't see very clearly of the target organ of the anesthetic. Okay, so hopefully by the end of the session, we will learn a little bit more and we can see a little bit more clearly. Okay, so we told you all about ourselves, and now we'd like to know a little bit about you. Okay, so if you can access the poll function on the right side of the screen on your panel, okay, and then if you key in your responses, to these. Okay, I'll ask Melody to take us through the polls.
So in the poll for the first question, we would like to know whether or not you are a consultant anesthetist or specialist in teaching hospital, whether or not you're in private practice, whether or not you are an anesthetist in training, a nurse, or you're not an anesthesia provider. And the response to the first question, so 50% of our, 14% not anesthesia provider, 64% consultant anesthetist or teaching in a teaching hospital, 7% in the private practice. We don't have any nurses amongst us today, and we've got 14% of us who are anesthetists in training. That's fantastic.
Yay!
So have a great time.
Welcome everyone. So at least we know, right, who's listening to us. That's wonderful. Okay, so for the next question.
All right, so if you are an anesthetist, do you anesthetize children every day, once a week, once a month, once a year, less than a year, or never? Let's have a look at the poll results. All right, so 8% once a year, 8% once a month, 15% once a week. None of us do it less than once a year. And wow, 69% of us actually look after children every day.
Yay, right. Mainly pediatric anesthetists. Thank you for joining us. Okay, we welcome everybody. But it's great to know that, you know, most of us anesthetize children every day. So this is important, right? Okay, so going on to the next question.
All right, so for our third question, do you use EEG monitoring in children, and basically how often do you use it? And our poll results are, all right, so we actually have 42% of us who have never used EEG monitoring in children. We hope you would consider at the end of today's lecture to use EEG monitoring in children. The numbers are changing.
Okay.
All right, so this is dynamic. All right, I'll reread the results.
That's dynamic.
It's dynamic.
Let's give them a little while to
respond.
respond.
Of us, we use it routinely, more than once a week. 26% use, yes, sometimes more than once a month. 21% of us use it rarely, so less than once a month, and 26% of us have never used it. So we really hope that for the people who are in the never used before category, that today we can encourage you to try using it in your practice if it's made available to you.
Absolutely. Okay, so it gets a little bit more challenging. There's no right or wrong answer, right? So take it away, Melody.
All right, so now question 4, how important do you think it is to monitor the EEG during anesthesia? All right, so 7% of us think it's not at all important. Oh, sorry, it's dynamic again. So 6%.
Yeah, maybe we give them a few seconds to do this.
Yeah, so 0% think it's not so important. 11% of us think it's somewhat important. 22% think it's quite important, and I'm very encouraged to see that actually the majority of us, 61% of us, think it's extremely important.
Great. Excellent. Hopefully that number will increase, right? Later.
Yes.
Okay. This is the last question for poll 1.
And for our last question, so what are some of the main reasons you don't use EEG monitoring? And this will be interesting for us to see. All right, we just give some time
yeah.
to come in.
Yeah, this needs some thought, right?
Okay, I think we can share the poll results.
Great.
Okay, so 6% of us think that EEG monitoring is unreliable. 6% of us think that EEG monitoring does not improve outcomes. Fortunately, nobody thinks that it's, nobody, all right, 0% people think that it's important. And then luckily 0% of us say, I don't know how to use it. 35% actually say they don't have access to EEG monitors. 15% think that it's too expensive. And we've actually got 30% of our respondents who use EEG monitoring routinely, which is fantastic.
Yeah, that's really encouraging. That's great to know, and it'll be interesting to know how if this will change right at the end of the
Yeah.
conference, right?
Yeah.
The workshop. I mean, so wonderful. So I shall now stop sharing screen, and then we will invite Patrick to give us a talk, his first lecture, which is basic EEG signatures. Okay, take it away, Patrick.
Hey everyone, let's talk about basic EEG signatures. My disclosures are the same as the ones before. So the central issue we have to deal with, I guess, in clinical anesthesiology is to figure out how much anesthetic to administer to a patient. And right now, say in the absence of EEG monitoring, the way that that is done is by looking at clinical signs like movement or changes in heart rate and blood pressure. But also it's based on, kind of a prior information using the pharmacokinetic and pharmacodynamic models that have been established for different drugs or inhaled anesthetics. And of course, this was a fundamentally important development in the history of anesthesiology to have concepts such as MAC or ED50s for inhaled anesthetics to know, on average, when someone might lose responsiveness to, say, a noxious stimulus. So that was, of course, an important development, again, academically and in practice for the history of the field. But we know that a limitation of that framework is that those measures, such as a MAC or an ED50, they're really only telling you the point at which 50% of patients are able or not able to respond. How do you gauge that for your individual patient, right? And I think that's where EEG monitoring really helps, because it's giving you that direct readout from the, as it were, brain compartment of a patient. It's giving you that instantaneous readout of what's happening. So let's review again that case that I showed earlier of the waveform, just to get a little more practice, again, visualizing the waveforms. It'll be important to look at both the waveforms and the spectrograms as you're reading out these EEGs. So let's look at this one again. So again, 4 seconds of time. Okay, the patient's awake. There's eye blinks here. Okay, and start to see some muscle activity here. All right, that's when the propofol is being administered initially. Again, creating that burning sensation. Now some oscillations, beta, slowing to alpha, alpha. Slow oscillation. And now we're into some suppression, burst, suppression, burst. All right, so we saw that earlier, but I think it's worth another review. So again, here these beta and alpha oscillations are indicating a sedative state. And actually, it's interesting. So, and then the next graph here, we see the slow oscillations that are indicative of a unconscious state, and more or less the reverse sequence happens during emergence. So, for instance, if you were to turn off the propofol at some point, let's suppose it was Ativa, or if it were a sevoflurane anesthetic, you were to turn that off, you'd see this pattern go. The brain would go from this pattern of slow and alpha to this, right? So if you see the EEG suddenly get like smaller and faster, you know your patient's waking up. Hopefully that's intentional, and if not, you know what to do. And then finally, this is overshooting into burst suppression. So we see again these suppression events followed by bursts of activity. So this is again an example of how you read that waveform. And I think that waveform, the utility of it is that it provides a kind of instantaneous readout. You don't have to wait for the spectrum to sort of accumulate and compute over several seconds of time. This is giving you kind of instantaneous feedback when things are changing rapidly, such as during induction. Let's go again into the basics here, just to define those different frequency bands. You'll see maybe beta and gamma oscillations, again, in a sedative state. So going from anywhere from 12 to 25 to 40 cycles per second. You'll see alpha waves frontally, 8 to 12 cycles per second during a unconscious state. Don't see too much theta, but you will see delta and slow oscillations appear in that unconscious state. And again, these oscillations are telling us something about the underlying activity of populations of neurons. So normally you require kind of subtle oscillations throughout, many different frequencies, going from, say, theta, alpha, beta, and gamma, sort of all the notes of that keyboard, if you will, to coordinate activity within and between different brain circuits. If you introduce these kind of large anesthesia-induced oscillations, we're disrupting that activity. And as I mentioned earlier, the scale of those oscillations with the anesthetic drugs is so much larger than endogenously generated oscillations that we're really introducing a quite profound level of disruption. And we'll come back to that inference about the scale of oscillations a bit later. So again, with propofol, we are seeing these two different oscillations, which sort of reflect two different mechanisms of action, actually, of the drug at a brain circuits level. So it's introducing this frontal alpha wave, which isn't normally there, and that seems to disrupt prefrontal thalamocortical activity, so disengaging prefrontal functions such as sensory awareness, attention, salience, executive function, or planning. So these higher level functions are sort of almost certainly disrupted by the presence of that frontal alpha wave. And then, as I mentioned earlier, the slow oscillation is signaling a periodic silencing of cortical activity, which becomes stronger and stronger as the slow oscillation sort of increases in size. And as I mentioned previously, the kind of peak frequency of that beta oscillation trends down into alpha frequencies with increasing anesthetic concentrations. This is true also for sevoflurane. And again, as you turn it off, the pattern will sort of reverse. So if you start to see the center frequency, the apparent center frequency of the alpha wave sort of increase, then that the patient is becoming more conscious. And again, hopefully intentionally. But it can happen with stimulation that can change. So let's talk about sevoflurane. So we didn't talk about this previously, but as I had mentioned, sevoflurane is a GABAergic, has many mechanisms of action, but it actually has a strong GABAergic mechanism. So it's not surprising that it looks like propofol. So we see the combination of slow and alpha oscillations. And at different points during this anesthetic shown here on the top screen, the sevoflurane concentration is decreased sort of transiently, and you can see these sort of transient increases. Let me actually just use the annotation on Zoom. These sort of transient, change the color here, increases in alpha frequency. Then at other points in time, the sevoflurane concentration is decreased. And so you see that alpha frequency go down, and then maybe the reverse is happening. So this is all, as a result of the, manipulation of the sevoflurane vaporizer. And then as the, where did my cursor go? As the concentration is increased, you can actually sometimes see this fill-in of theta frequencies. You also see, of course, an increase in the power and slow oscillations. That will, of course, happen as you increase the sevoflurane concentration as well. I'll clear that. All right, great. And this fill-in of theta frequency seems to be unique to the inhaled ether-derived anesthetics. So sevoflurane, desflurane, you don't really see it with propofol. So dexmedetomidine is, of course, a drug that you use very frequently as a sedative or as an adjuvant for general anesthesia. And it has a mechanism similar to non-REM sleep in that it increases activity of presynaptic alpha-2 adrenergic receptors, actually reducing noradrenergic signaling, and then as a result, through connections from the preoptic area to the brainstem, but also through direct connections from locus coeruleus to the cortex, you're actually reducing noradrenergic signaling. The net result is then to create a sleep-like state that's very similar, again, to physiologic non-REM sleep. And so consequently, you might expect the EEG to look similar to non-REM sleep, and it does. It doesn't look like propofol or sevoflurane. It has this character where you do see slow oscillations or slow delta waves present, as you should during non-REM sleep. But the sort of higher frequency wave here isn't that kind of continuous alpha wave, but it's actually an intermittent wave called a spindle that kind of waxes and wanes. You can see it on the spectrogram as sort of these little intermittent little bursts of activity between about 12 to say 14 cycles per second, so a little bit higher in frequency than the propofol or sevoflurane induced alpha wave. And then in some cases, you can actually see a slow wave in the absence of a spindle that maybe perhaps is reminiscent of a deeper non-REM 3 or slow wave sleep. You sometimes can see that. We quantitatively analyzed the amount of power in this dexmedetomidine-induced EEG. And so you can see that and compare that with propofol. So propofol is in red, dexmedetomidine is here in blue. And you can see that, vaguely there's similarities, right? You have a slow delta oscillation in both drugs, say dex, propofol. You have this spindle oscillation, which is similar in frequency to the propofol-induced alpha. And similarly is engaging a thalamocortical circuit, but the details really matter here. So it's not subtle. The propofol-induced slow oscillation is much larger than the dexmedetomidine-induced oscillation. Same is true for the propofol frontal alpha. And so, as I mentioned earlier, you kind of expect the larger waves, both the slow and alpha spindle, to produce a much larger, more profound disruption of brain activity. And accordingly, in this very deep state of propofol-induced unconsciousness, you cannot arouse a patient to recover consciousness, whereas with dexmedetomidine-induced sedation, you can arouse someone to recover consciousness and actually respond to a stimulus. So with ketamine, I had mentioned earlier that ketamine is blocking NMDA receptors at essentially the inputs to these GABAergic interneurons. And in doing so, it prevents those GABAergic interneurons from becoming active and firing. And then as a result, it prevents them from, inhibiting downstream circuits. And so that disinhibition, if you will, allows some circuits, say in cortex and in other areas, to become more active. And the net result of that is a increase in beta gamma oscillations that we see here. We also see that with nitrous oxide, you can see beta gamma power come on at some point during this transition from isoflurane to nitrous oxide. So nitrous oxide has a NMDA mechanism similar to ketamine. So not surprisingly, we do see that beta gamma power. But prior to that, during the transition, when isoflurane is maybe turned down a bit and the nitrous oxide is turned up, you do actually see a really pronounced slow oscillation, which is actually a kind of, if you will, deeper state of unconsciousness. It may be is suggestive of the two drugs sort of acting in concert constructively to produce a deeper, disruption of brain activity. So this is an example of isoflurane, again, switching to nitrous oxide. And as I mentioned, another way to think about this is the brain is being engaged in different ways by these neuropharmacologic actions, neural circuit actions, sort of dictating the notes that the brain can play. So the high frequency notes with ketamine, something like that. That dexmedetomidine, one note, intermittently, one note, and then that propofol with those two very strong bum bum notes that are very consistent throughout the anesthetic. So the current paradigm in brain monitoring, which actually a minority of anesthesiologists engage in, asks us to rely solely on a number between 0 and 100 to kind of read out the brain state, and I think that in a way doesn't match up with your training for other types of physiologic monitoring. For other types of physiologic monitoring, A, the underlying physiology, but B, in addition to any process information that's coming out, you're kind of correlating that against your knowledge of sort of the raw waveform, say of a blood pressure waveform, a EKG, respiratory trace, all sorts of other things you're reading out. You know what the waveform means, and you can correlate that against any kind of process number. So what we're saying here is that we can and this is obviously a oversimplification, right? It's sort of saying that this one number about the brain represents one underlying mechanism of anesthesia. We know that's not how anesthetics work. Like, there are multiple mechanisms, right? So we just want to update that paradigm. We want to say, hey, look, we know there are multiple mechanisms. There's a corresponding EEG pattern to that underlying different mechanism, and we can read that out in the EEG and use that to essentially better understanding what a number might be telling us, right? I'm not really necessarily criticizing the number. It can be useful, especially for tracking trends and changes, but it's very helpful to understand the underlying waveforms and the spectrogram patterns so that you can be sure of what you're seeing. So I'll wrap up here. In summary, as I mentioned before, the oscillations that we see in the EEG reflect fundamental underlying synchronization of brain circuits. Under anesthesia, those oscillations are huge, and we can use them to read out anesthesia-induced activity in the brain for different drugs. And every drug has its own characteristic signature related to its fundamental mechanisms. And if we look at the EEG, we can actually use that information to titrate precisely anesthetic requirements for every individual patient. We're going to see a lot of that in case studies. Dr. Bong is going to be showing you some wonderful case studies that she's been working on, currently in review, to illustrate all the ways in which you can use this EEG to monitor your pediatric patients. So thank you. And actually, I'll just mention, I'll show this slide again later, but there are EEG education resources you can go to. You can get free CME credit at eegforanesthesia.irs.com. And also my website has these short YouTube videos that can review some of this material again later offline. So thank you so much.
All right, thank you very much, Dr. Patrick, for that very enlightening talk. Now we would like to go on to our second poll of the day. This will help us to consolidate some of the knowledge that we have acquired from Dr. Patrick's first mini lecture. So can I have the next slide, please? All right, for question 1, which spectrogram is characteristic of propofol? Is it A, B, C, or D? You can input your answers in the right side of your screen, and we will be sharing the results and the poll answers soon. All right, so 38% of us have chosen B, while 63% of us have chosen the answer D. Can I have the next slide, please? So for those of you who have chosen B, you are absolutely right. B shows the spectrogram, which is characteristic of propofol. All right, now shall we move on to the second question? Which spectrogram is characteristic of ketamine? Is it A, B, C, or D? I'll give you some time to put in your answers. All right, so for question 2, 60% have chosen B, while 40% have chosen C. Shall we see the answers to see if you're right? All right, so for this, C is the one which is characteristic of ketamine. Can we move on to our last question for poll 2? Which EEG waveform indicates burst suppression? Is it A, B, C, or D? All right, so 100%, things are changing. 71% have chosen the answer A, while 29% have chosen the answer D. Can we have the answer? So for those of us who have chosen A, you're absolutely right. This indicates burst suppression. All right, so we've come to the end of our second poll. Now we'd like to invite Dr. Patrick to come back on to give his second mini lecture on the age-related differences in the EEG signatures. Dr.
Hey,
Patrick.
Melody, before we go on, could we go back a couple slides on the poll? I just wanted to point out a few things to kind of help people differentiate between the different signatures. Yeah, so actually, you can put up all the answers. Let's just go ahead and go through them. So the first question was which one was propofol, and a lot of people chose sevoflurane. Now go ahead and leave them up. It's fine. Yeah, put the answers up. Thanks. Yeah, a lot of people chose D as the spectrogram for propofol, and you weren't that wrong actually. So I want to point out that propofol and sevoflurane have that shared, GABAergic mechanism of action. So they both have, slow and alpha waves. So you're not that far off. I think the thing that distinguishes the two drugs is that with sevoflurane, as you increase the end-tidal anesthetic, that alpha wave will get closer and closer and sort of fill in the gap between the slow oscillation and alpha. So you can see the waves are a lot closer together, and all that space is almost in between is almost filled in with red. And so that's really the difference with say sevoflurane versus propofol. So based on that, you see that little fill in there on the right hand side, then you can, by process of elimination, say that, oh, that must be propofol, must be B then, because propofol never does that. I can't recall. The lecture was pre-recorded actually, so I can't recall we went through that in any detail, but I guess we're doing that now. Another thing, I think there was a little confusion between propofol and ketamine, and the key thing with the ketamine is that, again, it's playing these higher notes in this maybe closer to 30 cycles per second compared to the alpha band, which is like at 10 cycles per second. So with propofol, you get 10. With ketamine, you get a really concentrated wave around 30. And so that's how you know ketamine, again, playing those high notes. that's how you can tell the difference between ketamine and propofol. Well, don't. I think there's plenty of chances to learn and to anticipate or maybe respond to some of the previous questions about, reading a BIS or PSI number. I mean, I think, that's totally fine. But I think what we're trying to do is bring everyone's level with the EEG up to the standard of the other clinical monitors, where you really do have some depth of the underlying sort of principles, so that when the number is not reading right with your other clinical intuition, you can kind of see that in the signal. And to that point, responding to another question about, how these numbers have been constructed in children, it's really not clear how the numbers in general have been constructed. We know they're based on essentially these same waveform and spectrum features that we're seeing here. They're basically processing those and kind of sort of projecting them onto some number. So we know it's based on these fundamentals that we're trying to go through. How that gets sort of reinterpreted for children is a question. We just don't know that. That's a sort of proprietary secret. And I think that does motivate our need to understand more about the fundamentals. Another point along in that direction is that in older adults, I think it's fairly clear now that the current BIS algorithm tends to do a poor job of reading older adults, because the older adult EEG is much smaller than, say, a younger middle-aged EEG. And the patterns are still the same, but it's just so much smaller that the algorithm is often fooled into making the monitor read a bit higher numerically, and thus causing, in some cases when the patients are really old or maybe impaired cognitively, so they have a small alpha wave, sort of encouraging anesthesiologists maybe to turn up the dose and push them into burst suppression. So to say that more succinctly, there's plenty of evidence that older patients, say over 60, over 81, have a much higher likelihood of being in burst suppression, even though they're maintained at the correct level of BIS. I think I haven't looked as closely at and I'm not sure if it's even available, how the BIS was constructed under for children. But I think the converse is true for children. The waves are so much bigger that there has to have been some adjustment to the algorithm to account for that. And I think until we know what that is or have some more experience with it, it's better to know something about the fundamentals and have that help you interpret the number if that's what you're using. So.
Thanks very much, Dr. Patrick. We need to move on to the next mini lecture, which will be describing the age-related differences in the EEG signatures. Thank you.
All right, everyone. Now we're getting into some interesting things. It's going to get more and more fun as the workshop goes on. So now let's talk about age-related differences in pediatric EEGs. All right, same disclosures as before. So let's walk through actually sort of these age-dependent changes again. We saw that in the plenary lecture. Let's go through this again. So we've got a 30-year-old patient receiving propofol. We see the characteristic waveform oscillations slow and alpha. We've got this color scale here. It's the same for all the panels I'm going to show you. Let's look at an older patient, 57-year-old. We see slow and alpha oscillations present. How about an 81-year-old? What does an 80-year-old look like? So here's an 80-year-old. We can see the slow and alpha oscillations. Again, they're smaller. We could still use the EEG for monitoring this patient. We just have to change the scale to see those oscillations. I'll show an example of that later. That's going to be really important. Here's a 56-year-old. Their alpha oscillation kind of looks more like the 81-year-old. If we had more time, I'd get into this. I think for the older adults, maybe I'll summarize by saying that the older adults who have a smaller alpha wave have lower anesthetic requirements. That has been discussed in a number of papers. One paper by Shao et al. From my group in Anesthesia and Analgesia in 2020. And then another paper from Gutierrez et al. From University of Chile. I'm happily a co-author on that paper as well, also in Anesthesia and Analgesia, talking about lower anesthetic requirements correlated with small alpha waves in older patients. One other thing, I just thought I'd mention it now again, because I know some of you, many of you probably take care of adults as well. The smaller alpha wave in the older adult also correlates with increased incidence of postoperative delirium. So there's a paper, Gutierrez et al., that same group from University of Chile in 2019 that initially reported this for a subsyndromal delirium. And then more recently, Suzanne Koch and Claudia Spies from Charité Hospital in Berlin reported this year, I think also in ANA, that relationship between small alpha waves and postoperative delirium. Just thought I'd mention that, kind of useful information. So in the younger children, we see kind of the opposite pattern. The very large EEG oscillations that are kind of maybe getting a bit smaller through teenage years and certainly into adulthood. I'll mention one other thing here about the pediatric alpha wave. We're going to be talking about that a lot. There's going to be a paper just accepted, so in press, in anesthesia and analgesia. First author is Jerry Chao, C-H-A-O. I'm on the paper. Rodrigo Gutierrez, again, from University of Chile, also co-first author with Jerry on that one. And we actually found out that in the very young patients, less than 1 year of age, the alpha power is actually indicative of anesthetic requirements. So I'll just, maybe that's a little bit of a teaser. So keep an eye out for that paper. It'll be coming out later this year. So we see this sort of waxing and waning of EEG power. And what might be, the cause of that. So again, I just want to remind everyone from the plenary that in that first, several years of life, there's this explosion of postsynaptic buttons on the dendrites of these pyramidal neurons that through time get pruned away. And so there's this kind of very pronounced curve here where the synaptic buttons kind of show maybe a maximal density around 8 to 10 years of age. And we see that in the anesthesia-induced EEG with sevoflurane, say here, going up to 28 years of age, and with propofol shown here going up to 21 years of age. So we completely see that reflected in the EEG. So I think the strategy maybe that we take away from that is that in children that have a alpha oscillation, you could start to see it as early as 6 months of age, but more reliably maybe around 8 months of age. We can use that alpha wave and changes in that to maybe more precisely titrate the anesthetic concentration. Dr. Bong will be showing you many examples of that. I'll show you a few also here. But that would be the strategy for the children that have the alpha wave. Basically, use the same rules as adults, because the pattern, even though the power is different, the pattern is very similar to that in adults. And again, that changing alpha wave allows us to maybe very precisely titrate the anesthetic drugs, avoiding periods of emergence, but also allowing the child to emerge at the time when we need them to, and preventing oversedation, say by preventing entering into burst suppression. So then the question comes up, what do we do for the children, say less than 6 months of age, who don't have that pronounced alpha wave? So this is a more detailed look from Cornelison et al. of those first few months of life. So again, the 1 month, the 3 month old here don't have that alpha wave. The 5 month old, you start to see it actually. So you could definitely use that to help you titrate there. Here's a continuous kind of plot of the spectrum. Earlier I showed you the coherence, which isn't available on any of the kind of present day monitors, but the spectrum, the power you do see, and again, here you go, you can see that transition starting at about somewhere between 4 and 6 months of age. So as soon as you see that, you can use those higher frequencies to titrate. But yeah, what do we do about the younger kids? So I think the strategy for the younger children is that they do have that slow delta oscillation, and we can use that slow delta oscillation to help us be sure that the patient is unconscious, but also be able to detect periods of lightning. So my argument, and we'll see this in the cases that Chun will present, is that, you know, if you see that large sort of pronounced, very regular slow oscillation waveform that is sort of absent of higher frequency power, then that's a good indicator that they're, you know, deeply unconscious. If it starts to get smaller, and then you know that they're perhaps lightening. And again, that larger slow oscillation we see with propofol, say compared to sleep, is signaling, you know, more pronounced periods of neuronal silencing in the cortex. So again, if those neurons in the cortex, cerebral cortex, are silent for, you know, long periods of time, the cortex is essentially unable to process information. So you can feel very confident that the patient is unconscious, and that sensory processing maybe isn't fully propagating up to the cortex. Okay, great. So we reviewed, you know, those EEG signatures. Now let's look at maybe some case studies. So here's, so I want to review certain patterns that we're going to see in the case studies here and in Dr. Bong's presentation. So this is a patient that is receiving sevoflurane and nitrous oxide for maintenance of general anesthesia. So we see here, I forget how old this patient is, maybe 1 or 2 years old. We do see activity in alpha band. We see slow oscillations here. There's a little bit of a fill-in. Then we see a little bit of kind of beta activity here. That's very typical when nitrous and sevoflurane are given together. So it's almost like you're marrying the pattern for nitrous alone with which is normally beta and low gamma oscillations with sevoflurane. So the combination of those two is sort of spreading out frequencies into that beta band. Okay, so now what happens when you just turn everything off? Okay, so what happens is, just like with propofol, this kind of alpha peak frequency is drifting up into beta frequencies, drifting up. The slow oscillation is kind of getting smaller, so it's going from this very hot, dark red color to kind of a lighter red color. And then at some point, the patient wakes up and the higher frequency oscillations just shut off, and are kind of spread out across, you know, all the frequencies. The piano keyboard can play again, and then these little things here are actually eye blinks. All right, so that's sevoflurane and nitrous, both turning off. So, and here's another thing, burst suppression. So we saw here in the waveform these periods of very small EEG alternating with periods of kind of larger EEG, which kind of recapitulate that slow and alpha oscillation that would have been present. Oops, no. So in the spectrogram, we see periods of blue that correspond to the very small EEG. So small, again, is like a low power, low signal. So that's blue, again, mapping onto blue here. And on the Massimo monitors, I think that Dr. Bong will be showing later, they actually annotate the EEG and kind of mark out these blue segments with a black line. So you'll see black bars there during suppression periods on the actual clinical monitors. All right, so this is burst suppression. So now let's take a look at another case. This is a 9-month-old patient receiving a ureterostomy. Anesthesia was maintained with sevo plus nitrous, and there was a caudal anesthetic with 0.25% bupivacaine. I'm showing here heart rate on the top trace, blood pressure here in the middle, and then now we have our EEG spectrum here. And this is a 9-month-old, so their frontal alpha is not fully developed, so you can still see it there though. And you do see the effect of the nitrous here in this beta oscillation sort of adding on top. During this case, so we're at this point 195 minutes into the case. And during this time, I was actually present for this case. We were recording EEGs for, research purposes. We could not intervene in the anesthetic. So the anesthesiologist was not aware of the EEG, wasn't using it, didn't plan on using it for monitoring, was just doing kind of the normal monitoring of heart rate and blood pressure. Okay. And then of course, at this point in the anesthetic, maybe the surgery would be ending soon, but actually for this case, the surgeon needed to continue working. There was something they discovered that caused them to need to kind of extend the procedure and do some additional work. So the case is going on. And of course, maybe there might be a worry that the caudal anesthetic is starting to wear off. So let's just kind of scooch forward about 10 minutes. Okay, so what do we see here? So I'll just kind of pause, maybe reflect on this. Okay, so just take note of the heart rate, blood pressure. So let's scoot forward another 10 minutes. Okay. And again, there's no change in the SIVO or nitrous, just that's being maintained. Okay, so now the red line here, the patient moves. You can see immediately after that, there's a skyrocketing, heart rate. At point 2, the anesthesiologist gives a bolus of propofol to restore unconsciousness. And then what happens after that is you see this period of blue indicating like complete silence for several minutes. And then I think at that point, the SIVO and nitrous was also turned up because you can see the peak frequency sort of dropping down. And then thereafter, throughout the case, the SIVO and nitrous are maintained at a higher concentration. The heart rate remains elevated, probably in response to the fact that the mean arterial pressure has dropped and is kind of staying low throughout the case. And, if I were a parent, I would be concerned. That's certainly not an ideal situation. And certainly this whole situation was avoidable if the EEG had been monitoring, because early on you could see that alpha wave was dropping out, and then eventually everything was shifting up to higher beta frequencies, which is a pretty clear indicator of a lightening, a recovery of consciousness. And this is transpiring over a period of minutes. So you could have definitely, detected it if the patient was being monitored. And this is in a review article that we have published last year in ANA Brandt et al. That goes through this case in more detail. So that's an example of how even for a young 9-month-old, you can still use the EEG and monitor changes in slow oscillations, alpha oscillations to detect changes in level of consciousness. So here's a 19-year-old patient coming in for sigmoidoscopy for chronic constipation. That should be, I'm an engineer, but I know that case is probably pretty short, maybe 20 minutes or something. It could be less. But this patient routinely takes anti-epileptic medications, suggesting that maybe he might have higher anesthetic requirements because he's likely to kind of process, metabolize the drug more quickly. And then he's also 90 kilograms and has a history of aggression and behavioral issues, also suggesting maybe a higher anesthetic requirement. So that's tough. You need more medication, but it's a really short case. So what do you do? What they decided to do was to pre-medicate with oral ketamine and midazolam, and then they induced with 1.1 milligrams per kilogram of propofol, and then maintained an infusion of propofol of 350 micrograms per kilogram per minute, which is a lot, right? That's like maybe 3-4 times the maintenance dose for a typical adult. So here again, my team was in the operating room recording EEG, but not able to intervene. This was for research purposes only. And plus, the people doing the recording were med students, so it's not like they would have had any, sway over what happened. And it all happened really fast too. So what happened was there was a delayed emergence for 2 hours, for an endoscopy procedure, right? And the people in the endoscopy suite actually called us up and were like, "Hey guys, can you come back and put that EEG strip back on and tell us what's going on?" Well, we didn't do that, but we analyzed the data, and here's what happened. So initially, there's the midazolam plus ketamine. So it's, again, that combination of beta oscillation you might get with midazolam, right? It's a GABAergic agonist. So for sedation, you get this. Ketamine also kind of produces activity in this beta range. So this seems reasonable, not surprising. There's some slow delta oscillation here too. So this patient might be quite sedated at this state. Now you've got the start of the 350 mic per kilogram per minute infusion, about 100 milligrams of propofol are administered in 2 boluses. You see a much stronger slow delta oscillation now, and a slowing down alpha frequency. So this is kind of a full-on general anesthesia right here, and maybe you need it. Maybe that this sigmoidoscopy is quite stimulating. Who knows? But what happens after that's not acceptable. I mean, why is it that this patient is basically isoelectric? Their brain is completely shut off, no neural activity for 12 minutes. That's unacceptable. That's way more anesthetic than you would need, even after turning down the infusion to 200. And then the patient emerges, but as we know, it's really a delayed emergence, 2 hours. That's unacceptable, right? The anesthesiologist would have no way of knowing that this was going on without EEG monitoring. Had the anesthesiologist been looking at the EEG, maybe they would have known that they had already given enough and they didn't need to continue the infusion. And it turns out actually that these patients with autism spectrum disorder, maybe alluding to a comment I made very early on, they've got the smaller alpha wave, right? This kid is 19, smaller alpha wave. The smaller alpha wave tells us that they are more prone to go into burst suppression and maybe have lower anesthetic requirements. And it's actually true. We reported in this paper that autistic patients who received, doses of propofol equivalent to their neurotypical counterparts, they were actually twice as likely to be in burst suppression as the neurotypical patients. All right, let's talk about a case of awareness. I think this is really important. Most of the cases I just showed you, dealt with, over sedation, right? And the cure for over sedation is less sedation. But if you take that too far, you'll get awareness, and I want to show you what that looks like. So the patient coming in for liver transplant, and let me just fast forward here to the spectrogram and the SED line. So this is this is time in minutes here. So 10 hours plus here probably. And so we can see here in the early part of the case, for maybe about 2 hours, almost 3 hours, the patient is missing that alpha wave, right? There's no alpha wave present, and the slow oscillation is really, really small, right? So it's somehow transitioned from, kind of slow oscillation to alpha, and then the alpha goes away, and then the slow oscillation goes away. Correspondingly, the SED line index is reading quite high. So this is when the patient was conscious and aware. And it's difficult because in this case with a patient who has liver failure, who's older, that alpha oscillation is really small, and the overall EEG is really super small too. So to deal with this in these very sick patients, and you may encounter a very sick pediatric patient as well, the thing is to deal with a small EEG is to change the scale, adjust the scale so you can see the key features that you need to see in the spectrogram and in the waveform. So slow, alpha, and waveform. Really key for the very sick patients to change that scale and be very careful so that you don't miss the key features and then inadvertently under sedate them. So finally, I want to show one kind of example of how you can use the kind of EEG signatures for the other drugs in a colonoscopy patient who has a cystic fibrosis. She is, this is a case courtesy of Fred Shapiro from Beth Israel. And she's, she has cystic fibrosis, requires supplemental oxygen, bronchodilators, nebulizers. So her respiratory state is very, concerning. And she also has a history of chronic pain and anxiety. So if you wanted to turn down the sedation, and you definitely would, because you don't want to impair her, respiration, but you also know she has maybe higher anesthetic requirements at the same time. So that's really tough. So in this case, what happened was, I'll quickly kind of fast forward. So Fred used a propofol infusion of 50, 30, and then 20 mics per kilo per minute to produce sedation. He was giving little boluses of dexmedetomidine in blue here along the way. And then at some point, of course, over a 25-minute period here in total end to end. So the dexmedetomidine will sort of reach some effective concentration, and you'll start to see the propofol pattern for sedation give way and transition over to the dexmedetomidine with that one note, intermittently one note, sort of taking over as the patient emerges, and then providing some degree of sedation as she's emerging and not disrupting ventilation. Okay, so we're over time. Let me finish up. I guess the point is that the anesthesia-induced alpha waves start to appear, maybe around about 4 to 6 months of age. And when they appear, you can use that alpha wave to help you titrate the anesthetic. Definitely, you can use the slow wave to help you titrate. And for the very young kids, less than 6 months of age, that alpha wave, is not going to be present. So the slow oscillation is going to be your main indicator of that, of sedation or unconsciousness. And at all times, especially with sicker patients, you're going to want to adjust to the scale so you can optimally visualize those slow and alpha oscillations. And in particular, sick children, but patients with neurodevelopmental disorders may actually have lower anesthetic requirements. All right, thank you so much. And again, some educational resources that you can check out in follow-up if you have time. Thank you so much.
Hello, we're back. Great. I hope you had a good lecture. Okay, thank you, Patrick, for yet another fantastic lecture. Okay, and now we're going to ask some questions on the poll, just to make sure everybody is following along. Okay, because we can't really see you. Okay, so the first question on the poll is poll 3. Okay, alpha oscillations can be seen in infants. Okay, as young as what age? At birth, 1 month old, 3 months old, or 5 months old? If you've been paying attention to Patrick's lecture, that should be quite easy. So what do you think?
All right, we're looking at some of the answers now. So 50% of the people say 5 months old, and 50% say at birth. So actually the right answer is supposed to be 5 months old, but we'll get Dr. Patrick to go through the answers.
Yeah, sure. I mean, I think that's just the answer. When an infant is born, their brain isn't, fully developed at that point. Obviously, in that first year, there's a lot going on, and it just turns out that some of those prefrontal and thalamic connections are not fully functional, right at birth, and it takes a while for those to get connected. And so at around between 4 and 6 months, we start to see those alpha waves, say under sevoflurane or propofol, begin to develop, but not before then.
Yeah, that's right. And that's why clinically, when we put the spectrogram in like a 3-month-old, we basically just see slow delta and no alpha, right? Okay, so next question. Alpha power predicts anesthetic requirements in infants and the elderly. Is it true or false? Another easy one if you've been paying attention. What do we think?
All right, so it looks like everyone has chosen A, which is true, and that's fantastic. That's the correct answer.
Wow, you guys are good.
they've
You
been
guys are
paying
good.
attention. Excellent. Do we have another question? I think that's okay. Which of the following is an indicator of unconsciousness for all ages? Okay. So no matter how young you are or how old you are. So is it continuous alpha oscillations, continuous slow delta oscillations, intermittent slow delta oscillations, or continuous beta oscillations? What do you think? And Melody's gonna, yeah.
Well, it seems like 85% of our participants have chosen the answer B, continuous slow delta oscillations, while 15% choose continuous alpha oscillations. Does Dr. Patrick want to explain the answers to us?
Oh, right. Yeah. So it relates back to that first question, right? So in the infants, we don't see that alpha wave. So that rules out anything about alpha waves or beta oscillations. And as we had said in the presentation, the one thing that the young infants seem to have is that slow oscillation that's, kind of very smooth and continuous. And that should, correspond at some kind of neuronal or cellular level to that sort of intermittent, silencing of neurons. So it's that continuous slow delta oscillation, D, that's really an indicator of unconsciousness throughout the lifespan.
Yeah, even in the elderly, right, throughout the lifetime.
Absolutely, yeah. Your elderly patients or very ill patients will have those often, or the adults.
Excellent. Thank you very much, audience, for participating. And we are going to move on to Melody's talk right now, okay, which is very practical, the nuts and bolts of how you actually connect up these EEG monitors. We've got the BIS monitor and we've got the SET9 monitor. So she's done a very comprehensive video for you to see.
Good morning, everyone. I'm Melody Long, and I'm from KK Women's and Children's Hospital in Singapore. Today, I'll be sharing with you some practical nuts and bolts of EEG monitoring. I have no conflict of interest to declare. So why should we perform EEG monitoring? EEG monitoring helps us to monitor the state of the brain through real-time data acquisition and processing of EEG signals. This helps us to determine how much anesthetics are required to keep a patient at the right depth of anesthesia. These are some examples of pediatric EEG monitors on the market. We have the bispectral index monitor from Medtronic, the patient state index of the SET9 brain function monitor from Masimo, and the narcotrend index from Narcotrend. Today, I'll be sharing more about the first two, the bispectral index monitor from Medtronic and the patient state index of the SET9 brain function monitor from Masimo, because these are the two which are available in my institution. This is a picture showing you the Masimo SET9 setup. You can see in the picture on the right that the monitor is mounted on a stand with wheels, and this comes with hooks for looping cables and also a storage basket for new probes. The stand also comes with wheels so that you can shift the whole unit more easily. On the screen, you have the ability to monitor EEG waveforms and also O3 monitoring with the appropriate probes. On the left side of my screen, these are pictures of the cables which you will use to connect from the patient end to the machine end and the insertion points of the cables onto the machine itself. For the Medtronic BIS, the setup is a little simpler. You've got a screen and then there is a connection point for the cable. It comes with a mount so that it can be mounted onto any pole or placed flat on a surface. And this is the connecting cable to the patient sensor. These are the packaging of the various sensors from the two companies. They have got both adult sensors and pediatric sensors, and they are color-coded accordingly. Now we'll go through an overview of the steps to set up the machine. First, you have to turn on the machine. Then you apply the probe on the patient's forehead. You connect the probe to the EEG monitoring machine. You check that the probe is applied well. And now you are ready to begin monitoring and recording. This is how we do it in detail. For the BIS, the turning on of the machine is on the front. For the Masimo, The on-off button is on the side of the machine. To apply the probe, there are detailed instructions on the individual company's pack. But in general, we will have to wipe the skin with alcohol and dry, peel the electrodes from the tray, apply the electrodes onto the forehead, press the electrodes down firmly onto the forehead, and connect the sensor to the patient cable. In the bottom left of the screen, this is the sensor for base, and on the bottom right, this is the sensor for the Masimo. In this picture, we see that there are sensors placed on the children's foreheads. These are the connection points for connecting the probe onto the cable. So this is where it is on the left side of the screen for base, and the one for the SedLine Masimo is usually in the middle. How do we track probe placement? I'm going to show you a video for how to do so on the Masimo SedLine. So you see, you drag down the tab on the top of the screen. It will show up the sensor position, and it's color-coded as red, green, and yellow. Red means that there is very high impedance detected. Green means you're good to go. And yellow means there's average amount of impedance. To troubleshoot this, you will have to press more firmly across the points which show up as trouble spots, and then you check whether or not your probe is placed well again. For the base, to check sensor placement, you will go to the bottom left of the screen, and there's an icon which says sensor check, as highlighted by this red box. After you click on that, there will be a screen that appears with the various sensor spots. Tick means you're good to go. X means you need to try and apply more pressure on those spots because those spots are not reading well. So how does the screen look like during monitoring? This is a screen on the Masimo SedLine. On the top of the screen, you will see the PSI, and sometimes there's a notice that tells you that it's less than 25, which is low. Underneath that is a bar which shows you the electrode impedance. So like I mentioned, green means you're good to go. You will also be able to see the raw EEG waveform. This number here shows the patient state index. You are also able to monitor the electromyography, suppression ratio, artifacts, spectral edge frequency on the left and right. The color graph in the middle of the screen is the density spectral array. You can also label your session, and you can also note the time since the start of EEG monitoring on the bottom left of the screen. This is the screen setup for the base. You have the BIS index in the top left-hand corner, the electromyography indicator, raw EEG waveforms, a suppression ratio. You can also tell the spectral edge frequency, but it's small in this corner. And at the bottom of the screen, you can also see the density spectral array graph. What do the various terms mean? Patient State Index or BIS index is related to the effect of certain anesthetic agents on the patient. It ranges from 0 to 100. For PSI, the target range is between 25 to 50 under general anesthesia. And for the BIS, the target range is between 40 to 60 under general anesthesia. Electromyography, otherwise known as EMG, is a measure of detected muscle activity such as grimacing or jaw clenching. Suppression ratio, otherwise known as SR, is a measure of how much electrical activity of the frontal and prefrontal cortex of the brain is suppressed as a percentage of time. Artifact or signal quality indicator is a measure of how much physiological, non-brain related and environmental noise the system detects. The spectral edge frequencies are the frequencies below which 95% of the total power of the patient's EEG is located, and this usually ranges between 0 to 30 Hz. This is a video showing real-time monitoring and induction on the Masimo. From the video, you can see that the PSI has been gradually reducing, and the EEG waveforms themselves have also taken on slow oscillations. So what else can we do with these monitors? We can take screenshots, and this will be useful for us to review the case after the case is over. To do so, you press 3 fingers on the right margin of the screen. Press and hold and slide the fingers across the screen from right to left. You wait for the borders to light up and the screenshot is done. This is a video showing how this is done. How do you take screenshots on the base? First, you look at the left side of the screen and you click on the icon called menu. Then you choose this bar called snapshot. How do we scroll on the set line? You swipe left or right to the time points of interest. And this is a video showing how. And how do we scroll on the base? You look for an icon, the menu icon on the bottom left of the screen. And then you can look for a previous case, next case, and you can click on rewind or advance accordingly. In summary, how do we set up? First, we turn on the machine. Then we apply the probe on the patient's forehead. We connect the probe to the EEG monitoring machine. We check that the probe is applied well, and you're now ready to begin monitoring and recording. I've come to the end of my talk. Thank you for your time.
All right, thank you so much, Melody, for that very clear and elegant presentation. I definitely learned a lot from watching that. You know, usually I get the data, you know, well after it's been kind of inspected real time, and so it's nice to actually see that you can do all these things with the monitor. And I'm sure the audience found it, you know, very practically useful. And along those lines, so now, you know, we've kind of had the basic background, some science, some of the basic theory. We've gotten the practical nuts and bolts application from Melody. So now it's time for the main event. This is what you've been waiting for, the actual practical use of this EEG monitoring in actual cases. And so I want to introduce to you none other than Dr. Bong, who is going to be taking us through many different case studies where she'll be walking you through her thought process in managing different types of patients and how she uses the EEG, practically speaking, to help monitor those patients in many different scenarios that you guys are going to find really interesting. I have to say that I've had the opportunity and really the pleasure of working with Dr. Bong for the past, I don't know, year and a half, maybe even 2 years, like just kind of reading cases almost every week. We'd shoot for every week and looking at cases together with the idea that we were going to put together a review article on this, which is actually in review right now. And it has been, you know, such a pleasure. I mean, her, you know, depth of knowledge in this area is really tremendous, and I've learned a lot from interacting with her in that activity. And I have to say that the work she's done with her colleagues at KK Women's and Children's has just been extraordinary to really make the EEG an important part of their practice. I'd say I'm not aware of actually, you know, any other group in the world that actually has gone to the lengths that they have to really make EEG a central part of their practice for, you know, safety and reliability of anesthesia in pediatric patients. So without any further ado, let's hear from Dr. Bong. Cool.
We now come to the last mini lecture of our workshop, and I'm going to speak on the clinical utility of EEG monitoring in children. Here's a little roadmap. We've already learned about basic EEG signatures, age-related differences in EEG, and the practical nuts and bolts of EEG monitoring. So for this part, I'm going to speak on the clinical utility of EEG monitoring, about what EEG monitoring can tell us, and also we're going to go through some clinical scenarios where EEG monitoring has been found to be particularly useful for children. So, what can EEG monitoring tell us? Well, it can tell us if the patient is too deep, what we call over-sedation, or if the patient is too light, under sedation. We can see the effects of different drugs with different mechanisms of actions on the brain states at any given moment in time. And we can also have some insight about the different stages of brain development, particularly for infants. So here's what I mean by when a patient is too deep, when he goes into burst suppression during anesthesia. Here we have an 11-month-old who's on cardiopulmonary bypass. And if you focus your attention to the top half of the screen, top third of the screen, which is the time domain trace, you will see here burst suppression, which really is when the EEG becomes discontinuous, when you have periods of isoelectric or flat EEG alternating with periods of high voltage electrical activity. So that's burst suppression when you see it on the clinical monitoring screen. Okay, this is what you see on the spectrogram image. This is a 7-year-old who's having excision biopsy and undergoing sevoflurane anesthesia with fentanyl. So this is induction when he's having inhalational sevoflurane, and then he goes to sleep. You see the slow delta oscillations there. And then at this point, he lightened and went into laryngospasm. Okay, somebody was moving him when he was light. We had to give propofol, a dose of propofol here, and here you can see him going into burst suppression. And it's represented here with a series of blues and greens here, but actually a discontinuous black line. So on the EEG, this is what you see. You have periods of isoelectric flat EEG alternating with periods of high voltage electrical activity. Okay. And so this is the same patient, and I want to show you what happens when he becomes too light. This is towards the end of the surgery, and he's having skin closure at this point. So we turn down the sevoflurane, and here you can see the spectral edge frequency, which is the white line here, going up. You can see the continuous slow delta oscillations, the red part kind of dissipating and disappearing. And then the alpha oscillations also becoming less prominent. So this is towards the end when the patient is becoming too light. And then moving further along, same patient here, who's emerging from anesthesia here. You can see here spectral edge frequency increasing. And then you can see here, there's almost no slow delta oscillations. And then the alpha also disappearing. And here you can see the EEG, very high frequency oscillations here. So this is like an awake waveform when the patient's awakening. So this is the entire spectrogram. I've just used different screenshots at different time points to illustrate that. And you can see that they're not obviously under the same depth. This is when the patient is too deep, when he goes into burst suppression. This is when he's too light. And this is when he's awake. Okay. So that's all well and good, right? But how can EEG monitoring help us? We saw that occasionally the patient can be too deep, or he can be too light. Okay, so knowing this helps us to be able to titrate our anesthetic doses, right? So it's just right. Occasionally, our patients are also hemodynamically unstable, right? Probably from the effect of the anesthetic itself. So you, again, want to avoid that. So having EEG monitoring can help us to minimize anesthetic doses. What we want to be is where the sweet spot is. Okay, when the patient is neither too deep, not too light, nor is hemodynamically unstable. Okay. Well, the thing is though, the sweet spot can be different with different patients, right? Who have different risk factors. So knowing this, having EEG monitoring can help us recognize the different anesthetic requirements, and so that we know at any given point in time where that sweet spot is. Okay. So I will illustrate what I mean by showing you different clinical scenarios where I found that EEG monitoring has been particularly useful. And these are all real clinical cases from our institution. I like to broadly divide that into groups where children benefit, right? Those who have unpredictable, or rather less predictable, anesthetic requirements, and some special clinical circumstances, which I'll talk to you in a minute. So for children with unpredictable anesthetic requirements, these are kids with neuromuscular blockade who receive a muscle relaxant, children with atypical neurodevelopment, those with altered conscious levels prior to anesthesia, and infants. So starting with children who are undergoing general anesthesia with neuromuscular blockade. Well, these children are unable to move, breathe, or cough in response to light anesthesia. And we already know that unintentional intraoperative awareness is more common in children than adults, with an incidence of 0.8%. And if they're unable to move and cough, then we're not going to be able to know that. In fact, autonomic responses such as tachycardia, hypertension, sweating, tearing, pupillary dilatation, these can happen with children who are light, but they're unreliable predictors of awareness. The absence doesn't exclude the fact that the child could be possibly aware. So having EEG monitoring allows us to be sure that unconsciousness is maintained when the child is under neuromuscular blockade. I will show you a case example of a child undergoing surgery with neuromuscular blockade. This is a 1 year, 2-month-old child undergoing oculopexy with circumcision. The general anesthetic was maintained with sevoflurane. The child had atracurium, was intubated, and had a caudal anesthetic on board. So this is the full spectrogram which we generated in the lab for the entire case. So this is induction, this is surgical incision, and this part is during emergence. And you can see already at different parts that the child is at different depth. So extubation there at the end. So at this part, you can see the child's a little bit lighter. You have the slow delta oscillations at the bottom here becoming a little less prominent. Likewise, at this point, the child is also a little bit lighter. You can see the slow delta oscillations there at the bottom. And then you have alpha and almost beta at the top there. So this is what you see on the screen clinically, and I'll just talk you through the case. This is the point where the child has already been intubated. Sevoflurane was kept at 2.2% in preparation for a surgical incision. Here's the surgical incision. The caudal is working nicely, and there was no change in heart rate and blood pressure. We thought, okay, so then the child probably doesn't need so much sevoflurane. We turned it down to 1.6%, and it still looked pretty good right here. Okay, you can see the spectral edge frequency edging up a little bit, but you know, we can still see slow delta and alpha oscillations. And then we decided, okay, maybe we turn down the sevo a little bit more to 1.5%. And here you can see the slow delta oscillations. You can see here the spectral edge frequency here increasing, and the slow delta kind of becoming a little less continuous, okay, suggesting the patient is lighter. And then we thought, okay, we better increase the sevoflurane back to 2.05%. And here you can see, okay, slow delta oscillations coming back, and the spectral edge frequency coming down again. Okay, so this is a simple case, but it just shows you that the patient's depth of anesthesia varies during different stages of surgery. Here I have 3 patients of different ages, okay, all undergoing similar anesthetic with sevoflurane, fentanyl. They received atracurium and they were intubated. I have a 10-year-old, I have a 2-year-old, and I have a 2-month-old. Okay, so the question is, after you intubate, okay, and prior to surgical incision, how much sevoflurane do you usually use for maintenance? What would you like to use for these children with different ages? Do you use the same, or do you use different concentrations of sevoflurane? Okay, for me, I use like 2.5%, right? I used to give everybody 2.5%. So that's what I did for the 10-year-old and the 2-year-old. So as you can see, these are the spectrogram of the 2-year-old and the 10-year-old. And you can see here, they have the same scale for power, okay? But even then, you can see here that the 2-year-old is lighter, right? The higher spectral edge frequency compared to the 10-year-old, okay? And they both receive 2.5%, but it's clear that the 2-year-old has slightly higher power, and then also appears to be a little lighter. And this is the 2-month-old, the spectrogram of the 2-month-old. And you can see is really a lot more blues and greens here, right? The scale, we already turned it down very low, but despite that, you can see that the power of the brain for this 2-year-old is much lower. And the sevoflurane at this point was actually only 0.9%. Okay, and you can see there's only slow delta oscillations here. So what I'm trying to show you here is that children of different ages have different anesthetic requirements. So it's not that everybody needs the same thing. Okay, and just in case you think only children of different ages have different anesthetic requirements, I'll show you that here we have 2 10-year-olds of the same age. They're under anesthesia, both having 2.5% sevoflurane, and also had atracurium and were intubated. And their spectrogram looked very different too. Okay, the one on the right was having cardiac catheterization, 2.5% sevoflurane, and the one on the left, habes spadias repair, also is receiving sevoflurane. So same anesthetic, different spectrogram, same scale for the power, different responses, different brain responses. Okay, so the one on the left actually is a little deeper, right? Lower power compared to the one on the right. Okay, so even children of the same ages can have different anesthetic requirements. So the other reason why EEG monitoring in children is useful is quite often I encounter patients who are like teenagers who like to ask, oh, they're really anxious and they're asking, how do I know I'll be asleep, right? So teenagers, there's always the fear of the unknown. They're afraid that they're going to be aware and lying there unable to move, okay? So even the act of just putting on the EEG monitor and showing them, hey, here's what your EEG, your brain waves look like when you're awake, and we can tell it's different when you're asleep, and showing them that we will be watching their brain. It provides a lot of reassurance to them, right? It goes a long way to reassure them that they will be asleep and we're going to be watching their brains, which is what we do anyway. Okay. So the next group of children who benefit from EEG monitoring is children with atypical neurodevelopment. Children with neurodevelopmental delay, for example, cerebral palsy, or if they have neuropsychiatric disorders like autism spectrum disorder, they may have different responses to anesthetic drugs compared to neurotypical patients. And children with cerebral palsy, they're already known to have a lower MAC to volatile agents, and they frequently have delayed emergence. I think part of the reason being we don't know exactly how much anesthetic they need. EEG monitoring helps us, and it provides insight into their brain states and allows us to precisely titrate anesthetic doses to meet the unique needs of these patients. So here I want to show you 2 12-year-old girls, okay, 2 cases. They're having total intravenous anesthesia for scoliosis surgery. Both of them underwent extensive posterior spinal infusion and instrumentation of multiple levels, prone positioning, and both surgeries involve significant blood loss. So we have the neurotypical child on the left and the child with neurodevelopmental delay on the right. They're both 12-year-old. And this is a spectrogram for the neurotypical child. And this is a spectrogram for the child with the neurodevelopmental delay. Okay, as you can see here, the scale is higher for the neurotypical child and very low for the child with neurodevelopmental delay. The child with the neurodevelopmental delay has got a much lower power. As you can see, the scale is turned all the way down to 5, and despite that, it looks a lot more blue and green compared to the child on the left, who actually has a higher scale, right? But despite that, it's showing that the power is lower with the child with neurodevelopmental delay. And spectral edge frequency was much lower as well. Okay, and as is the patient state index, showing that this patient on the right is deeper compared to the patient on the left. Well, how much anesthetic were they on? These children both received dexmedetomidine, propofol, and remifentanil. Okay, and you can see the child with a neurodevelopmental delay is receiving almost half the dose that the neurotypical child is receiving. So despite that, receiving half the anesthetic dose, the child is still much deeper. So this just goes to show that children with developmental delay may have different anesthetic requirements, often lower anesthetic requirements than neurotypical children. And if you don't monitor them, you may not realize that. Another group which I find, have kind of fairly unpredictable anesthetic requirements are children with altered conscious levels prior to anesthesia. These children can have poor GCS, either from primary neurological pathology, or they have been subject to trauma, infection, or they could be critically ill patients from the ICU who are on sedative medications. For these children, it's actually difficult to know if they're already unconscious to start with, right? To add to that, the kids are often hemodynamically unstable. The question is, how much anesthetic do you need to give? So here we have a 7-year-old from the ICU who is having, he has complex cyanotic heart disease. He has had recent cardiac surgery, okay, and he's here for cardiac catheterization. This child is intubated. He's on inotropes, midazolam, morphine, dexmedetomidine, and rocuronium infusions. So the question is, what anesthetic would you give and how much? So I told you this is what I did. I didn't know what to do, right? I had no information. So what I did was I put on the EEG monitor. And this is what it showed. As you can see here, this patient is 7 years old, right? And despite we would expect a kind of much higher power EEG than this. But here, the EEG has very low power, spectral edge frequency is very low. You can only see slow oscillations here. So the patient's very deep to start with. Okay, essentially he didn't need anything. We just continue with the current midazolam, morphine, dexmedetomidine, and rocuronium infusions. And at some stage, he actually went to burst suppression without, us doing anything else, so suggesting that the patient's deeper than necessary. And we actually had to cut down these sedative infusions. Okay, so that's the suppression for you. And then we had to cut down the infusion. So this case just shows that EEG monitoring can help to guide how much anesthetic is required for children with altered conscious levels. Another group who benefit from EEG monitoring are young infants. So young infants undergo tremendous changes in brain development in their first year of life. Okay, there's slow delta oscillations, which are present in infants of all ages. And we know that young infants, they actually lack frontal alpha predominance and coherence. And theta and alpha oscillations emerge only around 4 months of age. So clinically, we see that anesthetic requirements actually vary greatly in children in various stages of infancy. So this is a spectrogram, typical spectrograms of children from 0 to 3 years. And at 1 to 3 months, very often you only see slow and delta oscillations with minimal power at high frequencies. At 4 to 5 months, you start seeing the theta and alpha emerging. Moving on to 9 to 16 months, alpha and low beta range start to appear here, okay? And then at 19 to 37 months, the alpha frequency range then start to increase in power, okay? So that's infants. Monitoring them obviously will help in our titration of anesthetic. We now move on to special clinical circumstances where children benefit from EEG monitoring. These include children undergoing total intravenous anesthesia, patients who are hemodynamically unstable, okay, patients who are undergoing cardiopulmonary bypass, and those who are having different anesthetic combinations. So here, we'll first talk about children undergoing TIVA, okay? So target controlled infusions or TCI infusion models, they estimate the plasma or effect site concentration, right? And if you basically don't get any feedback on the brain response unless you put an EEG monitor on. Without knowing the brain response, often, if you don't monitor the EEG, often we intend to provide sedation for a procedure, but we end up giving general anesthetic because it's a continuum, right, of where the patient lies in terms of the spectrum of sedation to anesthesia. With excessive sedation, there's a risk of loss of airway reflexes, apnea, hypoventilation, hypoxemia, hypotension, and prolonged awakening. So EEG monitoring can actually help to prevent oversedation and enhance patient safety and experience. So here I want to show you two 12-year-olds, okay, both undergoing total intravenous anesthesia for orthopedic surgeries. The one on the left is having a fractured fixation. Okay, at this point, TCI propofol is running at 4.8 micrograms per mil plasma level. Continuous slow delta oscillations seen here. And then we reduce the infusion to 4.3 micrograms per mil. And here you see alpha oscillations emerging. You still see the delta, but you now also see alpha because the patient is a little bit lighter then. So this patient is having a full general anesthetic. Whereas on the right, this patient is having an excision biopsy, so a relatively more minor surgery. TCI propofol, peak fusor model, right, same as the other one, is kept at 3 micrograms per mil, okay, and then subsequently reduced to 2.2 micrograms per mil. You can see here the slow delta oscillations is there, but it's intermittent, it's not continuous, right? And then alpha oscillations is here as well, with a spectral edge frequency of 16 to 22. But both the slow delta and alpha oscillations are intermittent. They're not continuous. So this patient is having sedation. And in fact, he was very easily aroused at the end and was able to be discharged from the PACU within 10 minutes of reaching there. Okay, so what this shows is that EEG monitoring can help us to guide the depth of sedation. Next, we move on to another group, important group, which is children with hemodynamic instability. So hemodynamically unstable patients, they often require a reduction in anesthetic doses to minimize the effects of the anesthetics on their blood pressure, right? So we frequently titrate the anesthetic doses up and down. But doing this without the knowledge of brain states may actually lead to periods of light anesthesia, which can risk awareness, or the patient could have they could be unnecessarily deep, okay, which then risks further hemodynamic compromise. So EEG monitoring actually allows us to minimize anesthetic doses during conditions of hemodynamic instability to maintain unconsciousness while trying to maintain hemodynamic stability. Here we have an 8-year-old who presented with acute myocarditis and complete heart block. She was hypotensive on dobutamine. She was already intubated in the CICU, okay, and she was brought to the OT for transvenous pacing. This is the screenshot of her spectrogram here. You can see she was given ketamine in the ICU for intubation because she was hypotensive. And then we saw this here. Spectral edge frequency was pretty high because she had been given ketamine. Okay, but despite that, we saw that she had slow oscillations, right? So we kept the sevoflurane at 0.5%, the slow oscillations there. So we're pretty confident that she was asleep at that point in time. So we were able to give her rocuronium to maintain neuromuscular blockade. So at this point, the pacing wire went in, the blood pressure improved, and we're able to increase the sevoflurane to 1.3%. So the cardiologists were then busy, stabilizing and fixing the pacing wire, stitching it. And suddenly, at this point, there was a failure to capture. Heart rate plummeted to 20 beats per minute, and blood pressure became unrecordable. So we gave adrenaline, 5 micrograms per kilogram, and started chest compressions for about a minute. Okay. As you can see here, we lost electrical activity. Okay, patient went to either burst suppression or isoelectric activity during the resuscitation. But very quickly, she had return of electrical activity when the pacing wire was repositioned. Okay, the heart rate and blood pressure improved, and you can see she pretty much went back to normal electrical activity. And having the EEG monitoring at this point helped us to minimize the sevoflurane during the resuscitation, and we were able to restart it at 1.2% upon recovery when we saw that there was return of EEG activity. So we restarted the sevoflurane at 1.2% to maintain unconsciousness. So in this case, EEG monitoring helps us to minimize anesthetic doses during hemodynamic instability. Okay, so pretty useful. We'll move on to the next group of patients who benefit from EEG monitoring. And these are patients, children with congenital cardiac diseases who are undergoing cardiopulmonary bypass. These kids are vulnerable to perioperative neurologic injury. The initiation and separation from cardiopulmonary bypass, those times are frequently associated with periods of hemodynamic instability, which makes it very challenging to titrate anesthetics to effect. So in addition to cerebral oximetry, which we use routinely, neurologic monitoring with EEG monitors may identify periods of cerebral hypoperfusion, seizures, or unintended burst suppression, and potentially reduce the risk of neurologic injury in these circumstances. Here, I will show you the spectrogram of a 3-year-old who is having cardiopulmonary bypass for repair of partial anomalous pulmonary venous drainage, ventricular septal defect, and atrial septal defect. So the patient had an uneventful induction, had invasive lines put in, and here we're initiating cardiopulmonary bypass at this point. So with cooling, going on bypass, there's loss of the alpha oscillations. You can see it disappearing here. And at this point, we know the patient was deeper, so we decrease the sevoflurane. So as the patient continues to cool, on bypass, he went to burst suppression. Okay, so normally we run sevoflurane when the patient is on pump. Okay, so at this point we saw burst suppression and we knew the patient was probably deeper than necessary. So we decreased the sevoflurane. And then subsequently, with rewarming, okay, we can see here the return of the alpha oscillations. And at this point, we knew the patient was getting lighter, and we increased the sevoflurane while on pump. Okay, so it's pretty interesting. Here, EEG monitoring helps us to guide anesthetic dosing during cardiopulmonary bypass. And we do that routinely now for our patients. And often I find myself having to give a patient extra dose of midazolam when the patient is getting lighter, or if they're in burst suppression, maybe occasionally even turning off the sevoflurane altogether. Okay, the last group of patients I want to discuss who benefit from EEG monitoring, and of course there are more, but we're just going to discuss this as the last group, are children having anesthetic combinations. As Patrick already alluded to, different anesthetics act on different molecular targets to produce distinct EEG patterns or signatures. Okay, you've seen this earlier. Different signatures with propofol, sevoflurane, ketamine, or dexmedetomidine. The problem is when we use these in combinations, the effects of the drugs are often synergistic, right, and unpredictable. So EEG monitoring allows direct visualization of the effects of various agents on the spectrogram in real time. Okay, so it makes it easier for us to titrate the drugs to effect. And I will again illustrate this with a case example. We have a 10-year-old with complex cyanotic heart disease who had bleeding esophageal varices. Okay, presented on Christmas morning, just when I was about to go off call. So he presented for emergency esophageal gastroscopy and hemostasis, basically ligation of the esophageal varices. So the patient was quite anxious. We gave a little bit of midazolam, small dose, because he was hemodynamically also unstable. So you can see the effect of midazolam here, the slow delta oscillations here. We perform anesthetic induction with ketamine. Okay, and you can see the beta, the gamma oscillations up there. Okay, we then subsequently intubated him and then transitioned him to desflurane anesthesia. Okay, so you can see the slow delta and the alpha oscillations there. So although the spectrogram, or rather the PSI, patient state index, is reading quite a high number, and this patient is 10 years old, right? So technically 58 is kind of a high range for the PSI. We actually can see from the spectrogram, right, that we have slow delta oscillations, and we know the high number is probably a result of the ketamine. So we're not too worried about that. We know the patient was asleep. Okay, so in this case, the EEG monitoring helps us to actually visualize the effects of different types of anesthetic drugs. So through these case examples, I've hoped that I've shown you that from induction here to emergence, okay, different things can happen in the brain, right? And if we don't monitor the EEG, we would have no idea what's going on, like through the course of the anesthetic, okay? And I just want to summarize here what we've talked about. The EEG monitoring allows tracking of brain states under anesthesia. And you know that anesthetic agents have unique spectrogram patterns, which can be easily visualized. Our EEG monitoring will allow us to actually provide personalized care depending on each patient's individual requirements in real time, so like minute to minute. And these are particularly useful for children with less predictable anesthetic requirements, including patients undergoing neuromuscular blockade, children with atypical neurodevelopment, cerebral palsy, autism spectrum disorder, those with altered conscious levels, and those undergoing, special clinical circumstances, for example, TIVA those who are hemodynamically unstable and undergoing cardiopulmonary bypass or using, anesthetic combinations. Okay, so I hope you've seen the benefits of EEG monitoring. And remember, we talked about driving in the dark earlier. Okay, hopefully, having EEG monitoring will help us shed some light so we can actually see more of what is going on outside or in our patient's brain in this case. And with that, I would like to end my talk. So thank you very much for your attention. And now I would like to invite Patrick and Melody back so that we can all do our Q&A session. Patrick, Melody.
Hey, we're back. All right.
Hello.
Hey there. Great lecture. Thank you for that.
All right, thank you,
Thank you,
Dr. Ball. Thank you, Dr. Ball. Thank you, Dr. Patrick, for your wonderful lectures. Now we are going to take some questions. We've got loads of them, and I'm going to start with Dr. Patrick first, okay? So first question for you, could intra-op EEG predict delayed emergence?
Yeah, I think so. So for instance, at the end of a case, if you were seeing that your patient is like the extreme case in burst suppression, or they still have slower alpha oscillations. I've also seen scenarios where they just have a lingering sort of beta oscillation present. All of which are indicating various degrees of disrupted consciousness. Then it is possible that they wouldn't. They might have a delayed emergence.
All right. Also following this question about intraoperative EEG, the next question is also directed to you. Can the intraoperative EEG pattern be associated with emergent delirium in pediatric patients similar to that in adults? Because in adults, slow wave dominant anesthesia is found to be associated with PAPU delirium in some studies as compared to an alpha dominant pattern. So what's your take on that?
Right. Yeah, I would think so. I think that would make a lot of sense, and I think the work that the person is referring to is from Paul Garcia and Jamie Slay's group, and yeah, it would make sense that if someone is in a slow wave dominant state, if we want to call it that, they're still unconscious, right? And so they may have a slower emergence that could lead down a path to delirium, and I think also if we extrapolate a bit that the frontal alpha is really, that we see under anesthesia, is really a manifestation of a prefrontal cortical network that needs to be able to work at higher frequencies, say beta and gamma frequencies, to be able to kind of coordinate, activity across frontal and posterior areas to have sensory integration and to engage, sort of attention, for instance. And so if those areas are not sort of coming back, right, in terms of showing that alpha, speeding up to beta and gamma and disappearing, then that kind of would imply that the prefrontal areas that again are important for basically mediate attention and sensory processing, that those aren't going to be coming back, and therefore one might expect to delirium. So I would think so, yes, that those same patterns might apply in children.
All right, and one more question for you, Dr. Patrick. What are the relative usefulness of DSA versus the SEF versus index for neonates to toddlers to teenagers in monitoring anesthesia depth?
Right. So I think at the end of the day, we're talking about, like, say, an index or some other computed value. I think we have to just think a little bit critically, not too critically, but a little critically about kind of what goes into that, right? And there may be two factors. First of all, the waveform and the spectrogram are sort of the fundamental quantities that then get taken and dissected apart and then put into that index, right? And so if the algorithm makes index doesn't know about age, doesn't know that you got an infant, doesn't know that you have a 2-year-old, doesn't know that you have a 14-year-old, doesn't know that you have an 80-year-old that has like impaired cognition, doesn't know any of that, doesn't know about autism, you can't expect that number to know how to adjust itself to read for your patient. Doesn't know about nitrous, doesn't know about ketamine. You know about that. That's your job, right? You know about that. The number doesn't know about that. That number can't ever take your job because it doesn't know about that stuff. So you know about that. And I think our goal here is to basically teach you guys about what's in the EEG corresponding to those different, more complex clinical factors that are essentially, the reason you want an anesthesiologist there and not a robot, taking care of your kid. So I think from that perspective, the fundamental thing is to, try to become more and more familiar. It's hard, right? But I think with time, you become more familiar with the underlying waveforms, and you can use that to sort of help you when the maybe the numbers aren't as reliable. And I would definitely say that they aren't going to work well at the extremum of the ages, right? So, neonates, BIS, for instance, is definitely trained on alpha waves. I mean, as one of the key constituents. That isn't present in neonate. You can't trust BIS in a neonate. I'm not sure about the Massimo monitor. You can check it out, but I'm not sure that's I'm not sure that they've updated it for neonates. And then for the very old patients, especially if they've got some kind of underlying cognitive problem, they're missing an alpha wave too. And those monitors, those indices are, bound to be inaccurate. And so in those cases, that's when you use your, more, your deeper level of training, right, to help you.
Thanks very much for that, Dr. Patrick. So in the same line, there's this question about how reliable is the BIS monitoring for infants and young children, because the impression is that it's rather unreliable. So I think you roughly touch on that. But Dr. Bong, do you have anything else to add?
Yeah, I would say BIS or the set line, they're unreliable in infants. I think even I think the manufacturer will tell you this, right? Like the BIS monitor, I think they have a new module now, which is for pediatric, and which actually the BIS index, you have to understand that it's a proprietary algorithm that they use to generate that. The raw EEG is what you need, right? That's essentially the patient's EEG, and then they put a filter in, and then you get your DSA, you get your spectral edge frequency. So those are actually the patient's data, which we should get familiar with. What the machine then does to the data to generate this index is anybody's guess, because they don't necessarily share that with you. And at best, I would say that is, you can look at the trend, right? Most of the time for most kids. And I think for Massimo, for the set line, they tell you it's really validated for 1 year and above. So when you're looking at infants, it's technically not validated, but if you know how to read it, you know how to read the raw EEG, how to read the spectrogram, you know that you're not going to expect alpha oscillations under the age of 5 months. You're only going to get slow delta. Then you can interpret it. You don't need the number, right? And I saw a chat earlier by Dr. Angela Tan, who was asking, why is it that sometimes you see that the patient's almost in burst depression looking at the monitor, and yet the PSI number reads really high. So that happens. I see that a lot too, like for neonates and the very small infants. And I think the reason for that possibly is that because they have really low power as well. You saw in our presentation that neonates and young infants, they really have very low power. So you got to turn the scale really low, right, so that you can actually see the oscillations because they're so small. So maybe the machine, this is my guess, maybe the machine just actually interprets it as a flat line versus actually seeing the oscillations. And again, I'm not sure how the machine does that, how they come up with that. But you can see a patient who seems to be very deep and reading a very high PSI number, in which case I just ignore that. I look at, turn the scale down as low as possibly can. I look at the clinical parameters as well, of course, which you all do. And then you would then titrate according to that, rather than to look at the BIS number. And equally, I have seen them reading burst suppression, right? Because it's like flat. And then you get a really low number, but then the patient's almost awake, and so.
So along that line, there's this question about an age range where the BIS or PSI number becomes more accurate in assessing or predicting depth of anesthesia as opposed to reading the spectrogram. So I guess there really isn't an age range, right? Because at the end of the day, what's still more accurate or more predictive is reading the spectrogram itself instead of reading off a number. Is that right, Dr. Bong?
That is right. Although equally, it's easy to like a number, right? I like numbers. Like so I read these, I read the spectrogram, but it's very difficult to chart, right? It's difficult to chart the spectrogram on your anesthetic chart. So I do write the PSI, and I think the machines, they will tell you that, the manufacturers will tell you that. So under the age of 1, I pretty much just ignore it. For the set line, and BIS I think is validated for 4 years and above, the new module.
Mm-hmm.
But it is a trend, so I sometimes just accept if it's reading like what I think is supposed to read, right? I will look at it and I will chart it, and if it's trending up, I'll see is there any reason why it's trending up. If it's trending down, I would look at that too. So I don't completely ignore it, but it's more like taking it with a pinch of salt.
Right. I think that's such a wonderful answer, and I'll just amplify, maybe also add to that the waveform is also really important to look at. If you can change the scale, just as Dr. Bong said, so you can really see the features of the waveform will never lie to you, and it'll tell you instantaneously what's going on. So you look at that and the spectrogram; those two will never lie to you.
And this is a clinical question, Dr. Bong. So should we continue to turn down on the propofol infusion dose when the EEG actually shows an adequate depth of anesthesia? Because I think as clinicians, we get really scared when we turn it down, and then we are so worried that, oh no, it's your level of pitch is going to jump up. So what's your take on that?
Totally. And I see that Dr. Josephine Tan had asked that question. I mean, we're colleagues. So, and I see myself in that position all the time, right? You have a patient in the prone position having scoliosis surgery, and the EEG is like reading super low and almost going to burst suppression. Like, do I turn it down? Do I not? Because I really don't want the patient to start moving, and then because you're prone, right? What are you gonna do? So I get scared too. But so I think it really depends what you mean by does it show adequate depth, right? So if you're looking at continuous slow delta oscillations, and I would say, and making sure that that is not an artifact, right? Because sometimes neural monitoring can interfere with that, depending on where the electrodes are. And I've seen that happen, depending on where they put the electrodes, sometimes it doesn't interfere with the reading. After they take it off, it's completely fine. So I think you have to correlate that with the clinical information as well. If the patient's heart rate's nice and steady, blood pressure is nice and low. In fact, most of the time we're struggling with low blood pressure in those clinical circumstances. I would turn it down if they're going into burst suppression. But is it nerve-wracking? Yeah, it is. But I do.
Sorry, just one last question. Yeah. Given that there are a limited number of monitors available at the hospital, how would you prioritize who gets the EEG monitoring and who doesn't?
Right. And Melody, you know this, right? Because we do have only a fixed number, a small number of monitors, and we do share it amongst us. I think the person doing like the most at risk child, right, at that point on any given day gets the monitor. I think when we want to use it, like for example, and I think I've given you some examples of patients with relatively less predictable anesthetic requirements. People who are, say, neuro patients, right, or somebody from the ICU. When you have no idea what state they're in when they come, when they have reduced conscious levels and they're already on sedative infusions. I find that particularly useful, right? And cardiac patients, the nurses know, right, when we're doing cardiac, that we want the set line in or the BIS, whatever you're using. Major cases, scoliosis I regularly do, because when they're prone and you're having so many infusions on at the same time, TIVA, right? And it's really useful to guide. And very commonly, actually, we used to go into burst suppression, even when you're setting lines and things without realizing it. And neuro, I regularly do, if the surgeon allows it, which most of them do, right? In fact, the ones that I've worked with, they all like it. You just need to flip it the other way, so it's not interfering with the surgery.
All right, I think that's all the time we have left for questions and answers. We have one last poll just to check whether or not
Okay.
in our perspective. So I'll hand the time over to Dr. Bong. Dr. Bong, please.
Okay, can you see my screen?
Yeah.
Yes,
Okay,
yes.
great. So this is going back to our last poll, which really is revisiting the questions that we had for our first poll, right? So how important do you think it is to monitor the EEG during anesthesia now, after the lecture? After the workshop, I mean. Not at all, not so important, somewhat important, quite important, or extremely important. So Melody, can you collate the answers?
All right, so I'm happy to say that now 50% of our participants feel that it's quite important, and 50% of them feel it's extremely important. So that's great that we managed to have some
Excellent.
shifts in perspectives.
Wow.
Thank you. So, and the next question, we're so happy to hear that. This is why we're doing this. And this is why Patrick is staying up till like almost midnight on his side.
I would anyway.
Thank you. And now, would you consider using intraoperative EEG monitoring in children? Yes or no? No pressure.
Well, looking at the poll results now, and we have 100% yes. So that's a resounding yes.
That's great. That's wonderful. So glad to hear that. And the final question. Okay, of course, we have to live with constraints, right? What do you think would be the biggest hindrance, though, to you now that everybody's willing to try? What do you think is the biggest hindrance to you using the EEG monitoring in children? Do you still think it's unreliable, or it doesn't improve outcomes, or it's not important? You don't know how to use it. I hope you won't say you don't know how to use it after this, or maybe you don't have access, which is a problem. We understand that, or it's too expensive. Or maybe like me, you use EEG monitoring routinely.
So I'm just going to share the poll results. So 44% of our participants actually don't have access to EEG monitors, which is why it's a hindrance, and that's understandable.
Yeah.
33% of our participants actually already use EEG monitoring routinely. Unfortunately, we still have 11% who say they don't know how to use it. And 6% feel that the EEG monitoring is unreliable, and 6% also think that it is too expensive.
Okay, no worries. Okay, so I hope if there are any industry representatives listening to this, okay, so hopefully you reach out to our participants and bring the EEG monitor for them to try, so that they will have access to that. And also, if you still don't think you know how to use it, this lecture, this workshop will be available online, and of course Patrick's wonderful tutorial, which he had shown the slides on. So that will be really useful. Okay.
Right.
And now, remember we said about how, sometimes I suddenly felt like I was driving in the dark sometimes, and hopefully this workshop will shed some light, regarding our understanding of EEG monitoring. It doesn't kind of replace all the monitors that we have, right? Which is really, really important, but it kind of complements what we already have and just gives you that little bit extra information. And I hope that's useful. And it's really been a pleasure, having you all. And I'm sorry.
Yeah. Thank you. Thanks.
Yeah. Thank you. So,
thank you guys.